may I invite Dr. Rajiv Bhargav for the next talk, challenges in converting a high tibial osteotomy to total knee replacement.
Can I ask what preoperative PROM do you use?
No, I use customized PROM score from which is more for our Indian patients. If you look at the PROMs available in the literature.
Yeah, I know that. That's the question.
So I have customized and I have validated in my center, and with same score I use post-operative.
So maybe I can ask you to share that with me?
Yeah, yes sir.
Right, thank
you.
you.
It is almost like it is customized a little bit from your Oxford knee score.
I looked at lots of international scores. They don't fit us.
Yeah.
Our patients don't relate to them. How many blocks can you walk? How can you get out the car? All those things they don't understand.
Good afternoon, friends. At the very outset, I would like to thank Dr. Prasad and organizing team for having me here. Well, it's little difficult to concentrate post-lunch, so is my topic. So I'm going to speak on conversion of high tibial osteotomy to a TKR. Well, high tibial osteotomy is done for the correction of alignment of the limb, and osteotomy is done at the upper end of tibia. But in many cases, it's just a temporizing procedure and had to be converted later to a TKR. So we face lot of challenges. What are those? First come skin issues. There can be variety of incisions. So you'll have to choose a proper incision. There can be many ways to do it. It can be supratubercle, it can be infratubercle, it can be closed wedge, open wedge. What concerns us most is supratubercle closed wedge osteotomy, because that alters the kinematics significantly. Then there can be variety of implants. There can be simple implants which can be tackled at the time of TKR, or sometimes it has to be done in a staged manner. You have to remove implant first and then later stage do a TKR. Then there can be range of deformities, like it can be little under-corrected to grossly over-corrected. So both have their own challenges. Then there can be some other complications like non-union at the osteotomy site or infection, which adds another degree of complexity to the situation. Our principles of TK remain the same. We have to correct all the deformities, get the knee straight, get the hip, knee, ankle axis aligned. Flexion and extension gap should be parallel and equal, and there should be good patellar tracking. So we have to achieve whatever the situation. So previous incision, if it is there, you can ignore transfer incision, but if it is a vertical incision, either follow it or keep a safe distance. So that's what it is done. When you reach inside, there is always some scarring around the fibular head. So patellar retraction may be difficult on the lateral side, so always better to do a rectus snip or pin a tubercle to prevent avulsion of the patellar tendon. That's very important inside. Then removal of the hardware. Simple implants can be removed. However, if it is a complex implant, that it may require a stay situation, or if the implant is well below the tubercle, then it may need a rod to fix it. You can see, this was my own case, you can see there was some superficial necrosis. Fortunately, I got away, but you have to be careful with the skin incision. Next very important thing is, as you can see, the upper tibia is deformed. So always template it properly. You have to see whether your tibial component is going to sit properly or not. Or if not, what we can do? Either we shift the component little medially. Sometimes we may take the tibial cut in about 1-2 degree valgus to accommodate the implant, and we can reduce the valgus at the femoral side. Or if that doesn't work, you have to use an offset implant. So proper planning is very important. And the HTO always changes the slope, so be careful, use 0 degree slope. So most important is tibial cut. Remember here, we have to remove minimum of the bone. Because medial side was already worn out, lateral side, if surgeon has removed a wedge, there's a lot of bone loss from the upper tibia. So don't cut more than 2 millimeters from the medial side. Otherwise, you will end up with big gaps. Next problem comes in balancing the flexion gap. As we can understand, the knee was varus before HTO, and it was converted to a valgus knee. So there is lot of change in kinematics, and sometimes you have to internally rotate the femoral component to balance the flexion gap, which is contrary to the teaching that component should be externally rotated by 3 degrees or whatever. So to my junior colleagues, don't use fixed 3 degree axial rotation in case which is post HTO. Always use a block and take it parallel to the tibia. I'll show you now some of the cases. This was slightly undercorrected, so it was not a big challenge. It was converted into total knee. However, in this case, it was overcorrected. It was a valgus knee now. So here, to balance the flexion gap, I had to internally rotate the femoral component and later release the lateral retinaculum. And that's what I got. Now here you see there is gross deformity at the upper tibia. Here in this situation, I had to take upper tibia cut in 2 degree of valgus to accommodate the implant, which I reduced at the femoral side to get this product. So we should keep everything in mind. If that doesn't work, you should always have a implant which is offset. This was infratubercle, so not a big challenge. If there is an implant lower down, it should always be bypassed with a rod, remember. And this was a case of non-union HTO, which had to be corrected by a rod and a locking plate. Now we come to the literature. The good news is, although it is technically challenging cases, but results, once done properly, results are as good as primary. To summarize, better to do high tibial osteotomy infratubercle. Plan the skin incisions very carefully to prevent necrosis. Stay well below the deep fascia while removing the implant. It's very important because you have to do a lot of dissection. Remember to cut medial condyle very minimal, not more than 2 millimeters, and at 0 degree slope. And be prepared to keep your femoral component internally rotation, in internal rotation, to get a parallel flexion gap. And always keep offset rod handy. I thank you very much for your attention.
Thank you, Dr. Bhargav. Can you join us on the stage? I'll invite Dr. Jamal Ashraf for the next talk, Management of Periprosthetic Fracture in the Knee.
I have a question till then.
Can I ask a question?
Yeah.
So, Dr. Rajiv, very straight question, straight answer, please. You have a plate applied laterally for osteotomy or fossa fractures. In those cases, will you take the plate out along with your TKR, or would you like to stage your operations?
Now, actually, if it is a lateral plate, and if the plate is not interfering your total knee, you just remove the necessary screws and then leave it. Unnecessarily, no need to open it on the lateral side or stage it. Unless otherwise, if the plate is sometimes preventing you from putting the tray, tibial tray, otherwise you can leave it.
So I think that's what most of us have gone to now. We just take the screws out. But we've seen a lot of people taking the plate out and sometimes in the same sitting. So that's a very wrong thing to do. I think that's what we should send the message.
Sir, have you ever replaced an open wedge HTO by Synthesis? Synthesis open wedge HTO. Have you ever replaced?
Have you ever done a TKR post open wedge HTO?
Open wedge.
You mean the Tomafix plate? Is that the Tomafix plate you're talking about?
You have not shown any of them.
The problem comes when there is closed wedge osteotomy. Open wedge, usually no problem.
Yes.
Okay, thank you. I've been tasked to speak on periprosthetic fractures around the total knee replacement. My disclosure statement, being a small-time trauma surgeon, I'm in the wrong place right now. Now, when you want to treat these patients, a thorough patient evaluation is mandatory. Did the patient have pre-fracture knee symptoms? Is there an element of infection contributing to the fracture? So it is pertinent and very important that you get high-resolution X-rays to determine the stability and the bone stock. Now, this is a 75-year-old lady with 2 fractures. The younger lot sitting in the back will say, what's the problem? It's a straightforward treatment options. But wait for a minute. Abhi picture baki hai. So, the key to a good periprosthetic fracture management is your ability to work around the obstacles, the pre-existing implants. So, briefly going through the supracondylar fractures. Now, unlike fractures associated with the total hip replacements, these are most commonly noted in knees with well-fixed components. And many factors contribute to their occurrence, but the one that I want to emphasize on is the iatrogenic cause in my book, caused by arthroplasty surgeons, the anterior femoral notching during surgery. Now, according to the Cochrane's review, fractures occur in as high as 10 to 46% of cases in which there is a notched femora. A fact echoed by a study published in the Journal of Clinical Orthopedics that stated that a 3 mm notch would result into 30% decrease of the torsional bone strength, thereby consequently increasing the chances of fracture by 20%. So as a treating surgeon, what should be your goal of treatment? You want to make sure that you have a stable joint with complete fracture healing within 6 months and a range of motion being restored to the pre-injury status or a minimum of 90 degrees. Now, retrograde intramedullary nails provide good treatment options. They are superior to plates in the presence of comminution, but interestingly, are contraindicated in the presence of severe comminution, especially that on the medial aspect. If you're going to treat it with an IM nail, 3 points need to be remembered. 1, the length should go up to the level of the lesser trochanter. Number 2, always lock it with 2 screws. And number 3, be wary of landing into a valgus malalignment. If you are getting into a valgus situation, use polar screws to get your alignment corrected. Now, if you're dealing with extensive comminution, it is advisable that you do extramedullary fixation, and if the comminution is more on the medial aspect, you supplement your fixation with a medial plate so as to prevent a medial collapse. So, a few case examples. A 65-year-old lady who has a type 2 fracture. She's treated by my friend David Choon from Malaysia by a retrograde distal femoral nail. Now, with this amount of comminution, maybe an LCP would have been a better option. But more importantly, the length of the nail is not ideal. It is short, making it more prone to a Viper effect and a later stage fracture. This is a 71-year-old male who sustains again a type 2 fracture, but it has a large butterfly fragment. Now, this fracture was reduced and maintained by multiple percutaneously passed encirclage wires and then fixed with an IM nail. Why these encirclage wires? Well, in my opinion, it provides additional stability and produces a more conducive environment for fracture healing. Now, this is a case of a periprosthetic fracture in a 66-year-old lady, a type 1. Now, this I have taken from the AO Trauma Master Course data bank. This was treated with a distal femoral nail. So, in your opinion, is the reduction acceptable? Well, anatomical reduction is not the goal. Restoration of length, axis, and rotation are sufficient to get adequate stability. And if you see, this patient goes on to unite well, and at 15 months has complete return to pre-fracture status. Again, another case, a 71-year-old lady, but this time she has a long stem prosthesis in place. So options of treatment would naturally be extramedullary fixation. 2 points to remember. Your surgical procedure should be as biologically friendly as possible, so indulge in a MIPO procedure. Secondly, when making holes in the zone of the stem, do not use a drill bit. Drill bits are more prone to breakage when they come into contact with another metal piece. Use Tiemann pins to make your holes. And a follow-up at 1 year, good consolidated union. And finally, the last of the supracandular cases, a 64-year-old lady with a type 3 fracture. We're going down further. In such cases, very little bone is available for distal fixation. So how do we achieve adequate stability when the implant is already stable and you don't want to revise it? The smart move is to supplement the fixation, like I said, with a medial support. At 8 months, the patient comes back to us and the fracture appears to have united. But there is an area of susceptibility on the medial aspect, the marked by the orange. But that is not the reason why she's come back. She's come back because she sustained another fracture, a trochanteric fracture this time. Now, the treatment of this trochanteric fracture is relatively easy. You want to put it in a nail, fine. But do you want to take care of this medial aspect? In my book, yes. So what we did was we removed the distal screws, put in a long PFN, because I always like to put it longer nails in the elderly, then reapplied the screws on the lateral aspect. On the medial aspect, I removed the plate, cleaned the fracture area, put in cancellous bone graft, and re-put in the plate back in. The emphasis that I want to give to the younger surgeons here is, do not leave any area of susceptibility or question if you are operating the patient again. If you weren't operating the patient again, you would have waited and watched. But since the patient is going under anesthesia, take care of it. So, a revision should be considered when a fracture is combined with femoral component instability or poor bone stock. Now, the important point. Remember that it should only be undertaken by surgeons who have the adequate experience and technical support and skills. If you're a trauma surgeon like me, in the best interest of the patient, don't attempt it. Send it to an arthroplasty surgeon. Now, coming to the tibial fractures. Literature shows that these are often associated with malalignment or malpositioning of the tibial component. Now, unlike the femoral component, there's very little space available for fixation around the tibial component. And this amount of bone available for fixation is going to be the main deciding factor on the basis of which you will decide how to fix it. After all, fixation requires bone. So, a type 3 fracture in an elderly lady, this time even with a long stem prosthesis. So how do we fix it? Where's the bone? Let's analyze. If you see, there's more bone available anteriorly to the stem and less bone available posteriorly to the stem. Now, this is your guiding factor. Hence, I prefer to put the plate on the anterior aspect proximally. By placing the plate anteriorly proximally, you will have not only ability to put in more screws, but even bicortical screws. And this was a landmark paper that was published in the Acta Orthopedica, written by CW from Korea, who advocated for the first time for dual plating. Even at that point in 2006, he had advocated periprosthetic fractures as being one of the indications where dual plating should be done. An example of that, a 77-year-old lady, type 2 fracture. But the amount of bone available is very minimal. You cannot achieve adequate fixation with one plate. Therefore, 2 plates applied by MIPO, biologically friendly technique. There's only one key in the whole surgery. One screw will decide how it's done. This is the reduction cortical screw. Get your reduction cortical screw in place at the correct positioning, at the correct torque, and you will have your fracture reduced. Put in your plates first, the lateral and the medial, and then you will have optimal stability. Follow up at 14 months, bony union. Now, this was another 65-year-old lady with a type 2 fracture. She sustains 5 years post her TKR. Now, in my book, the proximal fragment was slightly bigger and I could have achieved adequate stability with a single plate. And that is what I did. The fracture was aligned, I put an anterolateral plate, and I thought I had good fixation on in the proximal fragment. 4 months down the line, the implant broke. Why did this happen? Is it just because I didn't put a medial plate? Well, if I analyze it, I see that the working length was fine, the plate length was fine, even the proximal screws fixation was fine. What I had not taken care of was the medial discontinuity. And because of that, it led to the failure. So we did a revision, put in an anterolateral plate, on the medial aspect put bone graft, and supplemented the fixation by a small LCP. So the key that I learned from this is osteoporotic bones are not going to forgive you. It is imperative that all columns are taken care of. And always ensure there is no stress concentration, or else your surgery will fail. And 6 months, it unites. So in conclusion, 3 points need to be remembered. 1, cases which don't need open reduction can be done minimally invasively, provided adequate reduction is achieved. But bear in mind that a MIPO surgery can never be an excuse for an improper reduction. Number 2, simple fractures should be treated by bridge plating following standard protocols and achieving relative stability. The key word is relative stability. In osteoporotic bones, rigid constructs will fail. Elderly don't want rigid things. Number 3, in the presence of extensive comminution or short segments, supplement the fixation with a medial plate. And the crux of my talk, the final sentence is, attempt revision only if you have adequate experience and expertise. Never hesitate to transfer your patient to the person who will do a better job than you. Thank you for your patient hearing, and I take this opportunity to invite you all to Lucknow for ICON 2023, where we will put you up beautiful shows like this, a beautiful choreographed Awadhi night by Muzaffar Ali of the Umrao Jan fame. See you again in December, Lucknow. Thank you.
Thank you, Dr. Jamal. Any questions to the panel from the audience?
I hope not.
Oh, नहीं करना।
हो गया? हाँ पर ठीक है यार, दोस्त हो यार।
Surgeon, don't attempt periprosthetic fractures on your own. Make sure you need to know who you need going to send them to.
And friends, you saw a beautiful lecture on periprosthetic fractures, but you must remember one thing. Osteoporosis is a very important factor contributing to periprosthetic fractures in trivial injuries. So, if your patient comes and gives a history of pain, which is generalized, just take care. Remember, don't ever think that treating osteoporosis is your physician friend's job. If it's your patient, it's your job. So don't ignore it.